Welcome to the Clinical Cousins YouTube channel, and we're going to be going over DKA versus HHS. This is part of our CCRN review series. So the first thing with this is to know is these can be complications of diabetes. What is diabetes? Diabetes is when the body does not or cannot respond to insulin, thereby elevating your levels of glucose in your blood. So what are some of the acute complications that can cause a person to go into DKA or HHS? So any condition that raises the metabolic demand on a person causes the body to have a higher demand for insulin in order to power the cell. The cell has to have energy. How does it get its energy? Insulin transports glucose into the cell to give it the energy it needs. It's the gas in the tank. So we have two main types of diabetes. We have type 1 diabetes, which is when the pancreas doesn't produce insulin, or it produces minuscule amounts. And we have type 2 diabetes, which can be when the body does produce insulin, but the cells or the target cells of the insulin don't respond to the insulin itself. So type 1, no production of insulin. Type 2, production or less production, but the cells don't respond to it. That's why usually type 1 is considered juvenile onset. It's genetic, or a lot of times it's autoimmune. The beta islet cells are attacked, so then we have a problem with the pancreas itself. Type 2 has been called adult onset. It is insulin resistant diabetes is what it's really called mostly now. Along with that, and we talked about like a lot of acute complications of diabetes that will lead into these conditions. Those are things like infection. Patient gets an infection, the body's demand for insulin, the cells demand to have more energy to fight through that infection increase, therefore your body needs more insulin. It doesn't have it, so you can end up in one of these conditions. Things that increase metabolism like drugs, like methamphetamines, cocaine, stimulants, Adderall, medicines for ADD, also drugs we may give like steroids, like corticosteroids for people with asthma or COPD. Those can cause problems with glucose elevation. Inflammation in the body anywhere, infarctions like CVAs, heart attacks, anything that increases your body's need and demand for more energy is going to increase your demand and need for insulin. So if we go into this, we'll go into the 3 P's and sort of the complications that come from those. Those are the most commonly known problems associated with diabetes: polyphasia, polyuria, polydipsia. We'll start out with polyphasia. Why do people get hungry? What's the complications of them get hungry? Why do they seem like they just need to eat and eat and eat when they're having a problem with diabetes? Why do they need to eat when their sugar's so high? Well, the problem is the cell doesn't recognize the sugar's high. The cell's not getting insulin, so the cell's sending all those signals to say, hey, I'm starving to death. I'm not getting the insulin, I'm not getting the glucose I need for energy. So your body can't pull in and metabolize those carbohydrates anymore. It has to switch over to fat metabolism. So because it can't utilize carbohydrates due to deficiency in insulin or resistance, it has to start metabolizing fat. When your body metabolizes fat, it's sort of a dirty process. That's why we go into this process in states of starvation. Or now with the new fad dieting, we have keto diets, and people they want to be in a semi-state of ketosis. So in these states of increased fat metabolism, we produce things called ketones. Ketones are things like acetylacetone or beta-hydroxybutyric acid. And those float around in the bloodstream and they cause your blood to become more acidic. Normal pH levels are between 7.35 and 7.45. A lot of times in states, especially like diabetic ketoacidosis, we start getting states where our pH gets much lower because without any insulin, we start going totally into fat metabolism. So it can happen relatively quick that you end up in a state of acidosis when your body can't metabolize any sugar whatsoever. We see that less so in states of type 2 diabetes, and we'll talk about that here in just a minute. So as your body goes into this state of starvation, you get the signal that, hey, I need to eat, I need more glucose, I don't want to starve, for some reason I'm starving. So you get polyphasia. Also in that process, you start breaking down fats, you end up in a state of acidosis, you've got acetones floating around. Your body in a state of acidosis to acutely handle that elevation in acid needs to balance your pH back. Your pH is very carefully balanced in your body. If it goes down to 6.8, you may not live very long. So we really need to get that balanced out quick. How does your body do that? Well, if it uses your kidneys, it can take up to a week or more to hold on to the amount of bicarb it needs in order to balance out the acid. But it can blow off CO2 relatively quickly. So the first thing your body will do in a state of acute acidosis is you'll start breathing deeper and you'll start breathing faster so that you're blowing off CO2. Your body's normal CO2 is between 35 and 45. As you breathe faster, it might approach 20, 10, 15, 5. You can almost blow off all your CO2 if you breathe fast enough, although you'll never hit absolute zero. So the more faster and deeper you breathe, the more you bring this pH back up to normal. So in diabetics, especially in people in diabetic ketoacidosis and type 1 diabetics, what we'll see is people will have Kussmaul's respirations. Kussmaul's respiration is just a deep and fast breathing over and over again. The other thing you're going to note in these people who have Kussmaul's that come in, we got 2 Ks here, and they all go with DKA. That's something we'll need for in the future when we start studying the differences between these two, is as they go into Kussmaul's, due to these excess keto acids, especially acetone, you'll smell it as they breathe out. That gives them the fruity, flavored smelling breath. You'll come in the room, you'll be like, it smells like a stick of juicy fruit in here. Well, what it is this person, if you smell ketones and they're in Kussmaul's, what has a K in it? DKA. They're probably in a state of diabetic ketoacidosis. Like I said, we'll go into that in a minute. So that's one mechanism of what causes the first P. Now we go into the second P, polyuria. What causes the diabetic patient to pee so much? Like, why are they making so much urine? Well, your kidney is made up of 1 million nephron cells, each individual kidney. So you've got roughly 2 million or more nephrons divided between both kidneys. In those kidneys, there's a beginning process that starts to filter your blood. It has podocyte processes, it has a proximal convoluted tubule, it has the loop of Henle here where loop diuretics work, the distal convoluted tubule, the collecting duct where the urine ends up going. So in that initial part of the kidney in the PCT, proximal convoluted tubule, there's a place where sodium and glucose are co-transported back into your blood. Okay, so this is the pre-urine, it's coming in here. We've got it and it's being pulled back in and we're bringing back our sodium and we're bringing back our glucose. This transporter here is called the sodium glucose co-transporter 2 and it pulls sodium and glucose at the same time. The unfortunate part about this thing is once levels of glucose raise to certain heights, greater than usually 250 milligrams per deciliter, this site can no longer hold any more glucose. You only have a fixed number of these. So if you use all your seats, what happens to the excess? Well, it has nowhere to go. So it ends up spilling down the nephron cell itself and making its way out in the urine. And the reason why it does this is the only part of the nephron cell where sodium and glucose can be pulled back in. There's no other place in the nephron to pull glucose back in. So if it doesn't get in here, that's it. It's going out in the urine. That's also why we find glucose in the urine of diabetics. Now, as this can't pull it in, it's trapped in here. The thing is the nephron cell itself is a semi-permeable membrane. It can actually allow water to pass back and forth. So we have all these little extra osmos creating a oncotic pressure. They're pulling water toward them. So what draws water toward it? Sodium, glucose do. So we have glucose, we have excess glucose now in our nephron cell and it's pulling free water toward it. Therefore, it's creating a state of what we call an osmotic diuresis. You'll see that with some medications such as mannitol. So with this, the patient is almost in a steady state of diuresis. They're losing volume, they're losing volume, they're losing volume. So they're polyuric. They're also a lot of times polyphasic, although like I said, we'll see this more with DKA especially. But polyuria, we're seeing that in both. The higher the sugar is, the more you diurese. That's an important point for later as well in differentiating these two. Also of note, this loss of free water starts causing a contraction of your blood plasma volume. So normally, let's say you had this much glucose in this much of a cup of water. You would say that concentration of that's not a high concentration of glucose per water. But if I take the water away while leaving the glucose and I decrease the concentration, well, now the concentration is higher even though I have the same amount of glucose, same amount of sodium. You see the concentration is increased simply by losing free water. This contraction of volume leads to the increase in concentration of the blood, which is what we call an increased osmolality. So the osmolality of the blood increases. Normal blood osmolality is between 280 and 300. In states of DKA, they go up a little, not a lot, usually to around 320. In HHS, they can go much higher. And we'll cover that in a minute. It's all based on the amount you diurese. So as osmolality increases, there's a receptor site on your hypothalamus, and on that receptor site, it measures the osmolality of your blood. If the osmolality of your blood is to increase, your thirst increases. There's things released such as vasopressin and other things, but they cause an increased amount of thirst, which leads to our other sign called polydipsia. So as the volume's contracted, the osmoreceptor goes, hey, I'm thirsty, I got to drink. You start drinking. However, the process of polyuria is ongoing because your sugar's elevated. Because you feel like you're starving, you keep eating, so you keep elevating your sugar.